Hi, good afternoon, everyone, and thank you for joining this webinar this afternoon. That is our December chapter call. So we're very delighted to welcome Dr. Tracy Frech, who will be presenting a year in review of the Medical and Scientific Advisory Board, where she currently serves as a member. Dr. Frech has presented at many patient education events throughout the foundation, as well as at several national conferences. We could probably take 10 minutes introducing her, speaking to all of her many accomplishments, but I think we're going to let her work speak for itself in the presentation. Just a quick housekeeping piece. This is a relatively new process for me, so thank you all for your patience. During the presentation, in just a moment, all participants will be placed on mute. If you do want to ask a question, if you'd like to ask a question, at the top of your screen, there should be a series of 5 icons. The second from the left is a little conversation bubble. If you open that, you can type in a question, and Dr. Frech either will answer it if she's able to during the presentation or at the end. And if time allows, what we will do is we'll take everyone off of mute and just have a few minutes of open conversation, so we may have time to do some Q&A there as well. So I am going to place everyone on mute. Dr. Frech, thank you for joining us.
Hello, and thank you for having me. I can't tell you how much I consider this an honor to be able to speak to the chapters on what has been going on in the Scleroderma research domain. It was a little bit of a daunting challenge, but I really wanted to organize this or present the information are informational articles that I truly believe can empower our patients and our providers to do a better job with scleroderma care. And what I was asked to do, let me see if we practice the outside. I might have you, David. It won't let me advance the slide now for some strange reason. Next slide. Perfect. What I was asked to do is to highlight research that's been going on in the last year with a focus on promising medical advances as well as clinical breakthroughs. The approach we'll take is to highlight scientific articles that were published between October 2016 and November 2017. And the way I did this is I went to pubmed.gov and I listed that website there because I think it's a great resource for patients. And these are the medical articles that were published on systemic sclerosis and localized scleroderma with the peer-reviewed process. So articles that appear on pubmed.gov pass several levels of scientific rigor. And oftentimes when patients come with articles that have not been placed on PubMed, this is a great place to refer patients to. The other place I looked was clinicaltrials.gov, and I wrote the link there for scleroderma trials that are sponsored by the National Institutes of Health. And again, these are really good critical sources of research that are funded, which means, again, peer review process has been done. What I then tried to do is I took the articles and I put them in different categories. So I focused on review articles, then therapeutics that could potentially be used in the clinical setting. And then there were several articles that I just found interesting, and I'll present those more as just a quick synopsis towards the end, just because they may apply to a certain patient population that is coming to the clinic. And again, my goal is really to empower patients and providers to understand if the research applies to their specific clinical case. Next slide. Okay. Okay, so the best review article I found is Systemic Sclerosis as summarized by Dr. Denton and Dr. Khanna. Dr. Denton is at the Royal Free in London, and Dr. Khanna is at the University of Michigan. I do point out on the bottom part of the slide is there's 2 honorable mentions that I think are nice to review on drug treatments. But why I particularly like this article and why I think it's really important for our patients to know it exists is it's a great guideline for how we screen for organ involvement with systemic sclerosis. And I think a good review article is super important for patients to have available if they're seeing a rheumatologist that perhaps doesn't take care of a lot of systemic sclerosis. It's a non-threatening way to make sure that you can educate the provider on how we screen for internal organ involvement and why it is very important. I will point out that under pulmonary hypertension, a Doppler echocardiogram is the screening for pulmonary hypertension, but the confirmatory test is a right heart catheterization. There is a star by this DETECT algorithm, and this is more applicable to non-U.S. sites, but does allow patients who do not have to an echocardiogram to have their provider go online and use certain pulmonary function test variables and lab tests to help guide them whether it is important to get an echocardiogram. And the DETECT algorithm uses a forced vital capacity on the pulmonary function test and a diffusion capacity on the pulmonary function test, the presence of telangiectasias, primarily on the face and hands, a serum, a blood test called an anti-centromere antibody, a BNP, which is a biomarker that's drawn in the serum, a uric acid, and we tend to think of that more for gout, but can be elevated in pulmonary hypertension, and a finding on an electrocardiogram which shows right axis deviation of the heart. And so again, patients can be empowered if they don't have a Doppler echocardiogram available. There are ways that a provider can use different clinical information to screen them for pulmonary hypertension. I'll also point out that with lung fibrosis, oftentimes patients get one set of pulmonary function tests with a diffusion capacity, that's the PFT with the DLCO at baseline. And oftentimes, I will see patients that are referred that had that baseline study but didn't have follow-up testing. And so I think it's important for patients to be aware that that follow-up testing of pulmonary function tests every 4 to 6 months in the first 3 years can be very helpful for screening for interstitial lung disease. And of course, a high-resolution CT of the chest can be confirmatory for the presence of interstitial lung disease. I'll move down to the bottom corner for kidney involvement, and oftentimes patients don't know what type of systemic sclerosis-specific autoantibody they have, and so I oftentimes say one of the important things for patients to do when they're seen at that very first visit is to have the presence of those antibodies there at that first visit so they can review the significance of what that blood test is. And you probably know that we don't follow autoantibodies over time. It's not a test that we see if it goes away. We usually use it for diagnostic purposes, but particularly with this anti-RNA polymerase III positivity, those patients are at a higher risk for renal crisis. And so patients should be educated on how to check their blood pressure and also to avoid prednisone. Now, prednisone sometimes needs to be used if there's an inflammatory muscle condition, but it should always be used with caution. And so patients on prednisone really do need to be checking their blood pressure regularly. Additionally, getting kidney tests and urine tests at a somewhat regular interval, and that can really vary by what physician you're seeing, but once a year at least, can really help us understand what is going on with the kidney. I'm going to move over now to the cardiac disease, and we've talked a little about the importance of a Doppler echocardiogram to screen for pulmonary hypertension, but we can also use other blood markers like the troponin or the BNP, brain natriuretic peptide, to get an idea if there's a presence of heart involvement. And it's becoming quite more popular in the clinical setting to obtain a cardiac MRI for patients that are at higher risk for heart involvement. And these patients tend to have either that muscle inflammatory overlap called myositis, or sometimes it's used in the clinical setting in young females prior to getting pregnant, because if there's some early indices of pulmonary hypertension, that's an important clinical parameter to catch. I will point out that in this box of gastrointestinal symptoms and nutrition, I'm sure many people are on the call for this particular reason. We really want research advances in this domain, but we remain really in the research setting directing our studies by symptoms rather than obtaining it on every patient, unlike the Doppler echocardiogram or the pulmonary function test. Really, the symptom-based investigations are being done only if there's a particular gastrointestinal complaint that the patient brings to the clinic. Importantly, I'll say next slide here. David, are you able to advance it one slide for me? Oops, there we go. Importantly, in the same article, there are several pictures that are available that I think is important for appeals for disability, as well as for patients that are having a difficult time getting access to different medication therapeutics. And let me explain this. So oftentimes, because we don't have FDA-approved treatments for systemic sclerosis, a doctor can prescribe a prescription or a medication, but getting that medication is quite a challenge, and it always takes a level of appeal. So the patient appeals to the pharmaceutical company, and the physician writes a letter. And I really liked this article because it has a visualization that I think is helpful for the review panel for disability as well as for review panels for pharmaceuticals to see that there can be bad outcomes if we don't treat this disease aggressively. Next slide, please. Additionally, on the same article, it highlights that there's treatments for systemic sclerosis. And again, that gets to the point that we need to oftentimes appeal for medications for our patients. And what they really want is a credible article to say that that's indicated. And here is that article that I really, again, believe can empower both the patients and the physicians to get access for screening tests as well as therapeutics. I won't read through each of these different boxes, but I will highlight that these letters over here indicate how much evidence there is. So an A-level recommendation means there's good data based on a randomized placebo-controlled trial that says that this recommendation has good solid data. When we get more into the C and D recommendations, these become more expert-based opinion or very limited evidence. And the reason I highlight this is a lot of folks probably have called in because they have a lot of questions on gastrointestinal involvement and levels of evidence. And we still need more good, credible research before we have the data to advise our patients. But I will also point out that we have patients' recommendation here as evidence B that they should receive anti-reflex treatment with a proton pump inhibitor or H2 blocker and antacids. And that recommendation is based on patients that are at risk for aspiration, so patients that have interstitial lung disease or active symptoms. This is a bit of a change because it used to be any patient that had systemic sclerosis was placed on a proton pump inhibitor for possible risk of reflex damage. And so we're really seeing that as we get more and more good evidence to advise our patients, we're able to put these review articles in press so that we can advise our patient population. On to the next slide. This leads us to our basic concepts in our systemic sclerosis treatment targets. And so based on that review article, I would say that there's a couple of take-home messages. We can say that blood and organ-specific screening can help physicians prognosticate or advise patients on potential outcomes and guide us on treatment decisions. I think we can also say one of the challenges, particularly as we go into these next slides on specific articles, that the rate of change in progression of systemic sclerosis and organ-specific involvement can be very, very different in different patients with systemic sclerosis. This makes clinical trial design really challenging. Now, the importance of this cannot be underscored enough, because when we read an article, we really have to say, does this information apply to my specific patient? And as we go through, I'm going to try to highlight some of the challenge as a provider in making that decision. But there is this concept for all systemic sclerosis patients that blood vessel injury or dysfunction causes that fibrosis and different amount of immune activation, which would then sustain that vessel injury. Now, that's a lot of words, so I made a little cartoon here. And, David, I may need your help here advancing the animation. And so first, we have that vessel injury. Next, that injury results in a stress signal from the blood vessel. And this is that term vasculopathy, or abnormality of the blood vessel. This is what we see when we do nail fold capillaroscopy. This is also over time which causes that pulmonary artery to change and puts patients at risk for pulmonary arterial hypertension. This is also what's responsible for scleroderma renal crisis. So we really understand that stress signal from the blood vessel is important. Animation goes a little bit further. That stress signal, one more, makes the support cells that surround the blood vessel upset or angry, and then one more animation there. And that cell is going to lay down different amount of scar tissue in different patients. So I was going to go back and forth and slow that up, but I think you get the point that cellular stress signal telling the cells around the blood vessel to lay down scar tissue is really what we're trying to target with our therapeutics. Next slide, please. So when we talk about targeted therapeutics, and just one animation here, we're going to pop in that star. We have to come with a caveat. There are no effective treatments or validated clinical response markers in systemic sclerosis. That's what makes this so darn hard. So rheumatologists that take care of rheumatoid arthritis, it's very easy to say whether a joint is swollen or tender. There can be a joint count, and then there is credible markers that you can use in the laboratory setting to help move drugs through the pipeline. So a doctor sees a patient, counts the swollen and tender joints, also sends some blood work, and we can say whether we think that drug is effective. In systemic sclerosis, based on that cartoon we just showed you, we have to ask the question, are we trying to do a vascular-based therapeutic? And in addition, are we trying to affect that immune response to the blood vessel? Or, particularly exciting in the last couple of years, do we want to not pay so much attention to the blood vessels or the immune system, but instead focus on that downstream fibrosis or scar tissue? So it is an antifibrotic response responsible. So with that background, let me tell you the articles I picked to review, because again, I think they have clinical relevance for all of our patients so that we can advocate for them. For the vascular-based therapy, I'll review an article that reviews combination with ambrisentan and tadalafil for connective tissue disease-associated pulmonary hypertension. So why that's so exciting is because it used to be for pulmonary hypertension trials, they excluded connective tissue disease patients because, again, they really are trying to look at specific outcomes. And it was only in sort of subset analysis that we could say, okay, we think this is probably how scleroderma patients are going to respond. But in this particular trial, it is, again, unfortunately, a post hoc analysis, but they purposely recruited patients with connective tissue disease so we can start getting some answers. So I liked that article. For immune-based, we're going to review the immunosuppression for the European Scleroderma Observational Network. And this is 50 centers in Europe that I think did a really nice study that can finally give us some guidance on how we use immunosuppression in early diffuse scleroderma. We'll talk a little bit about intravenous immunoglobulin. Many patients like this option because this is not suppressing the immune system, but giving immune function to a patient. And then lastly, we'll cover the antifibrotic dasatinib that was published, and I know that was one of those trials that was very exciting for the scleroderma world because mechanistically in the lab it made a lot of sense. So we'll talk a little bit about those results and why those are important to our patients. Next slide, please. So this is a first article that I highlighted, and I'm going to try to give you enough details why I think it's important and what the results, but I'm going to try not to make it too meta-speak that it gets boring. And I'm going to let you all type in the chat, this is boring, if you want me to move it along. So this is a post-hoc analysis. So like we talked about, they're going to look at all the data they collected, and we're going to really hone in on connective tissue disease patients and scleroderma patients. And what they were looking at as patients that had functional class shortness of breath with mild or moderate exertion. So these are patients that are symptomatic with pulmonary hypertension. Patients either received ambrisentan and tadalafil, so ambrisentan is an endothelin receptor antagonist, and tadalafil is a phosphodiesterase inhibitor, and those medications have been shown to be effective for pulmonary hypertension. So the question here is should we start with one drug and add something to it, or should we use both of those medications at the same time? And the reason this is such an important decision is a lot of our patients have digital ulcers. And as a rheumatologist, I am always begging my pulmonary hypertension experts to consider combination therapy. And the main issue with combination therapy has been it's very expensive, and we didn't have the data to justify it. So here's some of that justification. What they were looking at is, so those patients that got 2 drugs versus 1, how did they do? And that endpoint was either death or hospitalization or disease progression, or from a clinical standpoint, do we say there was an unsatisfactory response? And so they use a lot of patient-reported outcomes for that. Next slide, please. And so here is the slide. I'm not sure if you can see my mouse, if I have control over it, but I'm going to try to talk through the figure here. So here is how many patients that were randomized. These are patients that came to clinic and were consented for the study. The modified intention treat analysis says, okay, 5 patients between the time they signed the consent and came for the next visit dropped out. They didn't participate. The reason I really want to highlight this number is if you look in the literature, if you go to PubMed and you're trying to look to see if there's an article in systemic sclerosis, you oftentimes get discouraged because in all the cardiology journals or in rheumatoid arthritis, they have lots and lots of participants. In systemic sclerosis, we get down to very few numbers. But this is very exciting because here in the patients that they look at for this analysis, they have 118 systemic sclerosis patients. That's very, very good. And 187 connective tissue disease patients. I put this table over here so you can look at it to say, okay, what types of scleroderma patients do we have? So the N means the number of patients, and this is the percent of the total cohort. So about half of those patients had limited cutaneous systemic sclerosis, and for some patients that may have mixed connective tissue disease, that was about 11% of their cohort. And again, mixed connective tissue disease can evolve into either systemic sclerosis or really be characterized primarily by Raynaud's and hand symptoms with pulmonary involvement. So this allows us to say, again, every time we're going to look at an article, we're going to say, does this apply to me, and can I advise my patient based on this data? So the good news, again, is we've got lots of patients involved that have systemic sclerosis, and here is the breakdown of who received what therapy. This is a revised criteria, so let me explain a little bit about this. So 105 patients got excluded, and this was based on the fact is they went back and saw that patients that had a lot of what's called diastolic dysfunction, so the heart didn't relax very well, tended to have more side effects. So they changed their exclusion criteria to make this primary, or I shouldn't say exclusion criteria, they changed the analysis criteria so that they could get some good information on the patients. So they excluded patients that didn't relax their heart well, and now we're really just looking at pulmonary arterial hypertension. And this is the final assessment visit to show that from the combination therapy, we lost some patients here to follow up, and on the monotherapy we did as well. So when we get to the final study, and we're trying to interpret the data, we have 58 patients that had combination therapy, we had 18 patients that had ambrisentan, and we have 19 patients that got tadalafil. And we're going to just really, when we look at the results, think of those numbers, even though, again, we started with over 600 patients. Next slide, please. Oh, there we go. And I apologize because I do have some animation here, and it's a little bit behind that chat. But the point here is when we look at event-free survival, so we talked about those are the patients that got hospitalized or had a complication. We look here, these are all the connective tissue disease patients, and here are our scleroderma patients. So for the point of this talk, we're going to really focus on B. And why this is so important for education purposes is the combination patients statistically did better. So their risk reduction was 56% by getting combination therapy. So we finally have the data that we can argue that combination therapy for pulmonary hypertension in our systemic sclerosis population looks better. And that's really important because we do believe those medications are effective for digital ulceration. So we really have a better information to justify to an insurance company to get that combination therapy for pulmonary hypertension, and then also the benefit against digital ulcers or Raynaud's phenomenon. Next slide. And so here it is our hazard ratio, which I think is important to visualize to understand the results. So when we talk about hazard rates, we're really talking about condition in two different states. So here would be if there is a favored giving one drug. Here's favored combination. And if you've ever looked at these figures for lots of data in systemic sclerosis, most of the time we have the problem with it helps in one place, but it doesn't help with something else. And if we look at all these different potential complications, all of it favors combination therapy. And so while ideally we like to say, we would have like a hazard ratio of 10, so we'd say that combination frequency works 10 times better, we don't have really robust numbers, but we have enough data to say there's no harm and there's benefit. And we'll put that in the next slide. Here, which is our conclusion that our patients are benefiting from a combination therapy of an endothelin receptor antagonist and a phosphodiesterase inhibitor together. And the best part about this is there were not adverse events that were worrisome. The most common was peripheral edema or leg swelling, which was more frequent in the initial combination therapy than the monotherapy. But I will tell you in my own clinical practice, a little pearl I have, is before patients get placed on these medications, we often send the patients for something called an arterial brachial index to make sure they don't have vascular disease in their extremities. And then we get customized compression hose through the lymphedema clinic. And so when we start these therapies that may cause leg swelling, if the patients already have compression hose on, oftentimes they have that mechanical compression that doesn't get worse. So I think that is a side effect we could easily battle. And again, I don't think that the risk of adverse effect was seen in this article. So I think it's really an important article for our patients. Next slide, please. So this is, if we go, there we go. If we go to the next category of immunosuppression or immune modulating drugs, this is a really quite fabulous study, I thought, done by two authors I absolutely think are the leaders in the field in systemic sclerosis. So Arjan Herrick and Christopher Denton, both UK physicians, do wonderful work, and they put together a prospective observational cohort for patients that had disease onset of 3 years and less. And what they wanted to see is when patients were given either methotrexate or mycophenolate mofetil, that's CellCept or Myfortic, cyclophosphamide or no immunosuppressant, does one drug outperform the other for skin outcome? So the primary outcome was skin score, and they looked at these patients every 3 months for 24 months. And what they found is that out of 50 centers, they were able to get 326 patients enrolled, which is very good. The 65 received methotrexate, 118 mycophenolate mofetil, 87 cyclophosphamide, and 56 did not receive immunosuppressant. But here's a real caveat, and I really liked how they designed the study. So you might be thinking now, okay, well, gosh, why would a patient not be given treatment if they had early diffuse systemic sclerosis? This is an observational study, which means this is just patients that are getting routine clinical practice, and the physicians are looking at outcomes. These are not patients that are purposely not being put on drugs, so that's not blinded. The physician and the patient know exactly what they're getting. That's very different than the last study we went over. The reason that this is also important is these no immunosuppressant patients may have had a reason they didn't get drug. And so in particular, those are patients that may have been a little bit closer to that 3-year mark. Oftentimes we're using drug to try to stabilize a skin score. If someone's skin was getting better or stable off of therapy, they weren't receiving drug, that physician may have chosen not to initiate that drug because of the risks associated. Also, I think it's important because one of the questions my patients often have is one drug tolerated better than the other? And so they looked at all these different study exits and dropouts and saw no differences in tolerability between the 3 treatments. So people receiving drug, one treatment wasn't necessarily more toxic to the patient than the other. And so here is my busy slide to show you how hard it is for a physician sitting down with a patient to advise that patient on what we should do. Because every time we have a potential treatment option, we have to take into account the patient's characteristic. What was their age? What's their sex? How many months have they had of this disease? How many patients have received something else? Are they using steroids? Do they smoke? Do they have a history of cancer? What's their ethnicity? All of these variables are really important because oftentimes, like we showed in the last study, we don't have so many systemic sclerosis patients we're able to recruit to answer all of these different data points. So I do think it's important to realize this is the challenge. The other point I want to make on this very, very busy slide is one of the things I really like as I do my local registry work is to say, how did a patient feel? So if the skin score did not improve, but the patient felt a lot better, and that is a dramatic improvement, then we should note that, and that needs to be important. I'll also point out that we're not looking at patients in this particular study that had received stem cell transplant or any other immunosuppressant drug for more than 4 months, or patients that had that drug, another drug in the different category, for a month prior to study entry. So this is, again, there's some caveats to this study. Nonetheless, the results are very interesting. They show us here, and again, I know data slides are hard, so I'm going to talk us through this. So right here are each of the different skin scores. So it goes from 0 to 51. Here are our patients at a baseline skin score, then at 12 months, and then at 24 months. And this is what's called a box and whisker plot. So here's our median if you take all the patients of that cohort, and this was the range. And what we're looking at is methotrexate, mycophenolate mofetil, and cyclophosphamide, or no immunosuppressant. What were those patients at baseline, and how did they change over month or over 2 years? And then over here, we're looking at just the changes after 12 months. So again, that early, most patients who are just starting, they want to know what the next 12 months is going to hold for us. This is the distribution of those skin scores. So patients this is if you were worsening, and these were if your skin scores were improving. And we see, and this is the green line here is the median irrespective of what treatment you received. this line is how they smooth the data with this kernel density plot. But what we're looking at here is, does any drug seem to outperform the other? And here we're able to see that in that 12 months, patients really, here's the improvement. So patients didn't statistically significantly vary between whether you didn't treat the patient or you used cyclophosphamide or mycophenolate or methotrexate. Stated differently, if we're going to look at survival, so that's the most important outcome measure we have. So these are skin scores, but what about survival? There is no significant difference between starting mycophenolate mofetil, methotrexate, cyclophosphamide, or no immunosuppressant. But this is really why I liked this article is that's where statistics it didn't meet statistical significance. So we would say 0.05, you would say, okay, well, none of these drugs made any difference to no immunosuppressant. And I don't necessarily like that take-home message, because you can see that while there was no statistical significant differences between survival in these different groups, that we saw the least improvement in that no immunosuppressant group, and survival was the poorest in the no immunosuppressant group. So why is that important? I so often have patients who come to clinic and say, you know what, I really don't want to take immunosuppression because none of the data shows that it makes a difference. And perhaps here we have our first study that says, you know what, while it didn't meet statistical significance, it does show us that overall immunosuppressants for early diffuse systemic sclerosis may have a benefit over 12 months, and that while we still need to look for better treatments, we really have to take this improved survival rate in our patients that were treated seriously. So again, really well done study that says we really need to talk about using immunosuppressant in our early patients. And while the data doesn't quite support one drug over the other, using some drug probably is important because those patients do better. And if we have more and more patients working together with their providers and capturing this data in robust database, we'll finally be able to answer these questions. And in the United States, our equivalent of this is the Prospective Registry for Early Systemic Sclerosis. And those patients are currently being enrolled, and we're collecting data to do this exact same thing. But the European group has published this data, and I think we should take it seriously. Now, a lot of patients will say, if I don't get immunosuppression, how about other different safer therapies? And so intravenous immunoglobulin is something that's been studied quite extensively in France. And here this past year, they published the results on 46 patients. And what, again, you can see, the question is, of course, does this apply to me or my patient cohort? These are patients that were mostly female and mostly in their 50s. The different breakdown of disease duration and type of diffuse versus limited systemic sclerosis versus no skin involvement are listed here. And this is, again, the N equals the number and then the percentile. And then also what type of autoantibodies did those patients have. What we find here is, again, another busy slide, but again, I can't highlight enough how the characteristics of the study population are really the most important thing that your physician will review with you to say, well, was this patient that received this treatment like you? Did they have the same type of systemic sclerosis that you have? Because what we see for the results is that joint pain, muscle pain, and that muscle testing all improved significantly between the first and the last dose of intravenous immunoglobulin, as well as markers of muscle inflammation. Also, patients that had that muscle inflammation were able to get down on their corticosteroid. This is so important because we talked about corticosteroids being a real risk factor for scleroderma renal crisis. So again, an important article to help guide our therapies for our patients. And here's just to summarize again, clinical symptoms, lab values improved. There was a trend for improvement of reflux and bowel symptoms that are interesting and should be further explored, and that there was no downside for using intravenous immunoglobulin for skin or the cardiorespiratory symptoms. And there were really very rare adverse events. One was a blood clot and the other was diffuse swelling. And so again, another treatment option for our patients that can help support that appeal to insurance companies for this therapeutic. Moving on to our last moving on to our last treatment therapy, moving from immunomodulators to antifibrotics, is this article that was published on an antifibrotic, dasatinib. And so I want to point out this article for several reasons. First, 47 patients were enrolled, and as you can see, only 31 were able to receive the treatment. And then based on that, we have further patients that had to drop out due to adverse effects. And so we're only looking at 23 systemic sclerosis patients with a particular drug. And again, that's a real challenge in our patient population because what we want to do is to be able to have robust conclusions. And the robust conclusions are very limited by the numbers of patients that are in this trial or into the analyzed data. Again, always starting with, was this patient like me? It's the typical mean age we see for our studies, mostly female patients. And then what they're really looking at is lung parameters on pulmonary function tests, skin scores, and then there's this concept of biomarkers. So if you've ever been in a clinical study, you probably realize you get vials and vials of blood drawn. And the reason is there's a search to see, are there markers that show up that can help us predict who's going to respond to treatment. They also did a very fancy look at at high-resolution CT of the chest, which we'll cover in the next slide, to see, is there a particular improvement that we may have missed? Here we see that this is how the fancy improvement that they did on high-resolution CT of the chest. So it used to be in systemic sclerosis trials, we just followed pulmonary function tests. And there's been a real push to use more and more advanced diagnostics where we take the provider's eye out and we use diagnostic tools to see if there's a change. And so if you look here, radiologists may say, okay, that looks better, that looks stable, that looks worse. But what this is able to do is quantify the different changes in ground glass inflammation and fibrosis so that if a drug may make it a little bit better, the naked eye reading is less important than the computer doing the work. And so I think that's what you'll start seeing a lot in our different clinical trial reports. But why that's challenging for you when you go to the clinic is you're not going to get a fancy read like this. You'll just continue to get just the baseline high-resolution CT of the chest. And so that's some of the challenges is the research tools are not quite put into clinical practice yet. Here's to show you another kind of problem with clinical trials is out of those patients that received drug and completed the trial, only half of them had biopsies both before treatment and after. And what some of you may be aware of is there's something called gene expression profiling where we do skin biopsies and we try to say, are patients' skin more normal-like? Are they more inflammatory? Are they more fibrous or fibroproliferative, so to have more scarring? And getting back to that original slide, if we're going to try to target treatments, we want to know, do the genes expressed in the skin, so green and red show different directions of those genes, can we say, these patients are going to respond or not? And what we see in this particular trial, all the patients that had an inflammatory gene expression profile went into the non-improver category. Why that's so darn important is if we have an antifibrotic treatment available, these patients may need a dual therapy or a combination therapy with a medication that targets inflammation. Furthermore, when we look at the percentage of improvers of all those patients, this gene expression profiling helped us completely, right? It helped us say, okay, these patients with this intrinsic subset that were non-inflammatory are the improvers. And again, you wouldn't have known that by just the traditional markers of pinching the skin for that modified Rodin skin score. So I really just use this more to highlight that there's new techniques and tools coming available to help your doctor make better decisions. This also is shown in this slide here. The authors conclude that if we start looking at what do those genes do these send signals that are inflammation? Can we start breaking improvers and non-improvers into different targets for therapy? And that's a really nice aspect of this study. They're really trying to think of the next study that they can do to help guide therapy. So our conclusions were, what I sort of say frustrating to a certain extent, because this is the kind of the standard things we see in systemic sclerosis research studies. Even though the acceptable safety profile is seen, it doesn't have that significant clinical efficacy that allows us to say to the FDA and to insurance providers, let us have this drug for our patients. But it really does highlight what's coming and what's exciting for scleroderma research. We can use these gene expressions to help target therapies for our patients. We can also use it to help see if or we can also use more advanced diagnostic high-resolution CT of the chest to see if we can look at clinical outcomes. So again, a somewhat disappointing result, but a somewhat encouraging process on how the advance in research is occurring. So now we're going to do some by title only sort of studies. I'm not going to go through the detailed figures, and that was, of course, in the interest of time. But these were articles that I said, oh, good, these can help me treat my patients. And particularly as chapter leaders, you might have patients that come with specific complaints or problems that I thought these articles should be alerted and can help advise patients. So there's lots of case reports, and I know a lot of patients will complain that women with silicone breast implants develop systemic sclerosis after rupture of those implants. But unfortunately, when they looked at lots and lots of patients, they couldn't prove that association. And again, I think that really highlights that in a rare disease, the question really is, do we need even more patients? Or are there particular patients, there are a subset of patients that are at risk for this, and we needed to go back and look at the data differently. But why I liked this article is this is just a single case report. And what that means is a physician said, I took care of one patient, and I found this really to be very helpful, so I'm going to write this up so that other physicians can find it. And the hard thing is oftentimes it's hard to publish these articles because in the peer-reviewed journals they want lots and lots of numbers. But in this particular, this was published in Rheumatology International, and they said our patient received immunosuppression for systemic sclerosis, and the disease kept progressing. So we removed the implant, and they show here this immune tissue around the implant. And I have to tell you, I've seen the same thing in my patients who've sent me pictures post-implant. This clearly is abnormal in that the immune cells are being activated. And so they removed the implant, and then they gave this patient rituximab, which is a medication that suppresses the production of autoantibodies. And they found with the reduction of the anti-RNA polymerase III titer that the patient improved. And so I found that to be a really helpful or a valuable pearl. And after I pulled well over 700 articles to review, this one made it through the finer filter because that might be a pearl for a particular patient that they can bring that information back to their provider. The next, and I'm sorry, I've lost advancing control again. There we go. I wanted to make sure that I wasn't gender biased for my presentation. So I also try to find an article that could help our male patients. And for here, I thought this was very important because patients that receive cyclophosphamide or Cytoxan were found to have lower testosterone levels, significantly lower testosterone levels than patients who had not received cyclophosphamide. And why that's important is I do feel in our male patients we're not as good as doing bone density scans, and we should be better about that. And oftentimes when we get bone density scans, we'll find that there's a low bone density, and one of the markers, if you get a low bone density scan, that the provider is advised to check is testosterone. And so I think patients that have received cyclophosphamide or patients that have low bone density, this is a pearl for them. This is something that they can back to their provider and say, I want my testosterone level to be checked because there's data to suggest that my level would be lower since I received cyclophosphamide. So I liked that article for that reason. The next kind of hot area in all of rheumatology there are newer medications for cancer treatments that are called immune checkpoint inhibitors. And there's just been a flourish of publications that patients that receive these drugs develop autoimmune disease. And this is the first case report of scleroderma being induced by one of these medications. There's been lots of psoriasis and rheumatoid arthritis, but these were patients that developed scleroderma. And these are patients that had classic skin findings and Raynaud's, and these are patients that had to have the drug stopped. And even one patient who had the drug stopped, they ended up dying from the medication. So I think in particular, at a support group, that there's new patients that are coming with a new diagnosis and they are receiving newer cancer therapies. Because this is so new, having patients be aware of this association is important. Again, these are called immune checkpoint inhibitors and now have been shown to cause scleroderma. From a research side, this is a huge opportunity for researchers to better understand what that mechanism is so that we can do a better job in scleroderma research for treatments. And our final, sort of by title only, is this article that took 21 different studies on cigarette smoking and came up with a robust conclusion that smoking is associated with digital ulcers, changes in pulmonary function tests, and lung cancer. And the reason that's a really important final publication, you would say, well, of course cigarette smoking is bad and all patients should not smoke with scleroderma, is there was some mixed messages in the literature prior to this that nicotine may have an effect on fibrosis. And so I know I've had patients saying, should I stop smoking? And the answer is always yes. But finally we have that article to really prove that stopping smoking is a very good clinical consideration. And I'm sorry, my mouse is frozen here. Okay. So I've unfortunately only left us a little bit of time for questions, but I'll stay on the call and answer as many questions as people have. But what I wanted us to do in this year of review is to really understand that we're doing a much better job as a community, patients, physicians, pharmaceutical companies, and understanding scleroderma. And that allows us to do a better job with management, help us classify the disease better, and help us more systematically follow up patients so we have interventions that matter. And there's a real push to targeted therapeutics that are addressing both organ-specific complications and possible disease progression. And then lastly, that a patient-oriented approach should really take account all possible exposures that are associated with certain disease features. And so I really encourage, all patients to get on PubMed and look at what articles are coming and get on that clinicaltrials.gov to see what potential trials are available. Because every patient, while they are different, may have unique opportunities to participate in trials that will, or treatments that will affect them positively and make it important outcome change. And so with that, I think my very last slide is just a thank you, and if I'll advance it there. The thank yous are most important. And I like to thank my patients who allow me the pleasure of working with them, and they are such good participants in all of our various studies. I put a lot of different studies up here. I didn't give proper credit to the investigators and collaborators that made those findings, but I'd like to acknowledge them here. Of course, the Scleroderma Foundation, which is the most invaluable resource for our patients, and I applaud all of you chapters for making such an important difference in our patients' lives. And then, of course, my funding that allows me to do my work. And with that, I'm happy to take questions.
Dr. Frech, this is Steve Sapahi from the Delaware Valley chapter, home of the Future National Patient Conference in 2018.
Yes.
Thank you for the immense amount of work that it took to put this presentation together. It's clear that it was an undauntable amount of research, and certainly you've put it together so that even the naivest of us could understand it very well. My question to you is, do you think that this would be something that would be packaged as a good CME program for rheumatologists who aren't necessarily familiar with scleroderma in some of the outlying areas of our territories?
I would be super happy to do that, and I think so. I actually think that willingness to prior authorize medications and go for disability insurance for our patients is really where a lot of the local folks do need resources, because I think if we're advocate for our patients, we can get good treatments and again, the disability insurance they deserve. But it does take knowing which articles will pass muster. And, so yes, I would be happy to do that. And more so if there's particular providers that just say, is there someone I can talk to, I'm happy to do that as well.
Thank you.
Thank you. Anyone else? All right. Well, we will, if there aren't any more questions, I'm sure there's a lot of information to take in. If you have any questions, if you want to direct those to Carrie or Ron or to me, and we can get those to Dr. Frech and then kind of keep the conversation ongoing. I would like to say that, well, first of all, thank you very much, Dr. Frech, for participating. One of the reasons why we have this conversation today is because the question came up through one of the chapters that said we need more kind of hands-on understanding of what's happening in research. So I thank you all for asking these questions and helping us to provide these opportunities across the organization. This presentation is recorded and will be available if you'd like to share it with your support groups or with your board or any other group. I'll have it available. It'll probably be tomorrow. Dr. Frech, thank you very much.
Oh, my pleasure. And thank you for asking me. And again, if questions come up after the fact, super happy to answer them.
Thank you. Thank you very much.
All right. Thank you, everyone.
Thank you, and happy holidays.
Thank you.
Thank you.
Thank you.